My name is Gilmara Meine. I am an assistant professor of gastroenterology at Fevale University in Brazil. On behalf of all co-authors, I want to thank Gastrointestinal Endoscopy for the opportunity to share the findings of our study entitled Endoscopic submucosal tunnel techniques versus flexible endoscopic septotomy for Zenker's diverticulum as thematic review and meta-analysis. Flexible endoscopic septotomy is a minimally invasive and effective procedure that involves incising the midline septum between the diverticulum and the esophageal lumen, from top to bottom, and the cutting is extended almost to the bottom of the diverticulum, up to 5-10 mm above the base to avoid perforation. After the procedure, clips can be placed at the defect space. Since we don't completely excise the septum with flexible endoscopic septotomy, some patients may experience recurrent symptoms. However, recent advancements in interventional endoscopy have led to the development of endoscopic submucosal tunnel techniques such as Zenker peroral endoscopic myotomy, also known as ZPOM, and peroral endoscopic septotomy. Both uses submucosal tunneling to achieve a complete septomyotomy, which is a prognostic marker of procedural success. Here, the key distinction between ZPOM and peroral endoscopic septotomy lies in the approach to the submucosal space. As shown in figure 1a, in ZPOM, the submucosal bleb and incision are made 2 cm proximal to the septum. So, this technique requires tunneling for some distance along the esophagus to expose the septum, followed by submucosal dissection along both sides of the septum. In contrast, as shown in figure 1b, peroral endoscopic septotomy creates the submucosal bleb and incision directly over the septum, allowing for more direct access and also improve the working space during closure. Both tunnel techniques allow complete septomyotomy, as shown in figure 1c, followed by closure of the mucosal incision by clip placement. In our study, we conducted a systematic review and meta-analysis of 9 comparative observational studies that included a total of 759 patients with symptomatic Zenker's diverticulum. Among these patients, 40% underwent tunnel techniques. Our analysis revealed that endoscopic submucosal tunnel techniques increased the probability of clinical success by 15%. And tunnel techniques also showed a trend toward reducing clinical recurrence compared to flexible endoscopic septotomy. However, both groups demonstrated comparable results in terms of technical success, procedure time, and hospital stay. Moreover, the risk of overall adverse events and major adverse events, such as esophageal perforation, aspiration pneumonia, and bleeding, were similar between the groups, and most complications required only conservative management. To assess the robustness of our findings, we also performed subgroup analysis based on follow-up duration, less and more than 12 months, diverticulum size smaller and larger than 2.5 centimeters, type of tunnel technique, ZPOM and peroral endoscopic septotomy, and publication format, full text and abstract. The results are constant across all subgroups, further validating our conclusions. In summary, the systematic review and meta-analysis indicated that endoscopic submucosal tunnel techniques are a safe and effective alternative to flexible endoscopic septotomy for treating patients with Zenker's diverticulum, offering increased clinical success and a potential reduction in clinical recurrence. However, randomized control trials are needed to confirm these findings. Additionally, despite the proven efficacy, the broader application of tunnel techniques might still be limited by the scarcity of expertise in third space endoscopy. Once again, we thank Gastrointestinal Endoscopy for this opportunity, and we appreciate your time and interest in our work.